to our speakers. You will have to just pass the microphones to each other. And the first question that I will ask is the question to nobody specifically, and that's because I think each project that we heard from is related to that question. So whoever has an answer, please answer. How do different social barriers impact patients' ability and confidence to advocate for their own health? Who wants to take this on?
I'll just start us off because we're limited in time. It's Laura speaking. That's a big question. Why did I offer to start off? I think perhaps one that came to mind right away for me was the question was about barriers to people like self-advocating. And I think there are certain narratives, and here I'm getting academic, there's certain narratives in society, so like stories that we tell about types of people and groups of people, and there are narratives that say who's allowed to self-advocate, who's allowed to behave in such a way that they are perceived as perhaps an advocate, or perceived as pushing for what they need, or what their community needs. And there are narratives that say some people aren't supposed to be like that. Some people are supposed to be passive. And so I think that's one of the biggest barriers that I've experienced, and that first one that came to mind. Who else has something to say about this?
This is Kennedy speaking. I think one of the things that's really challenging about this question is that one of the requirements of navigating our healthcare system is that patients have to advocate for care. And we see this a lot in genetics healthcare, where this is kind of a niche service or something that not everyone knows about, some of the lack of awareness stuff that I talked about earlier. And it shouldn't be up to patients to have to advocate for care that's required to achieve health. So I find this to be a really challenging question from that perspective, because it's putting a lot of the onus back on the patient who's already navigating some sort of complex interaction with the healthcare system or reduction in health. So I find this question, I know I'm not really answering it here, but I find it really tricky as a clinician that a lot of the responsibility ends up falling on patient advocacy.
Thanks, Kennedy. I will move us on to the next question, and it is for Jennifer specifically, our top voted question at the moment. So food insecurity is an example of a challenge in health equity between meeting immediate needs and more effective but longer-term structural change. What narrative strategies can we use to address it? Does that make sense?
I'm digesting the question.
I know.
I mean, I think this question is what stories do we need? Like, what stories do we need to actually make a difference?
I think so.
I mean, so this is, I guess, my call to action for why we need artists and scholars and literary scholars with us. Like, I am a registered dietitian and a health researcher. I don't know from discussion of narrative discourses and like even the question, I don't have the expertise to solve that myself. So, I think our Hungry Stories project together is imagining how do we draw on storytellers and other kinds of knowledges to figure out how to do this. There was a question flashed on the screen about like what types of stories make a difference. And I even just reflect on like the last hour, all I can see is like the yogurt container on the screen and like the pictures of the children. Like it's the stories that we remember from these sessions. Like nobody's gonna remember the date, no offense to my beautiful data, but like, so the question is what kinds of stories do we need? I think we need the kinds of stories that move people, that they remember, that they want to read to their kids. What you call that? I don't know, do we have any literature scholars in here? I think we need the stories that we connect to, that move us, that make us see ourselves in them, that make us be able to envision a different kind of future. Because so far we're like stuck in one approach and almost don't give ourselves permission to envision a better way. So I want the stories that help us see what's possible. What you call that, I have no idea.
Thank you, Jennifer. I'm going to sync up with what we had 1 second ago on the screen, and that was a question for Manvi. Do you find your social advocacy work is ever in conflict with your work as an academic, and how do you navigate that conflict?
Awesome question. I actually wrote a paper on this, which is funny, because I was like doing this thinking then, but also it was a research paper for a class, so I was like, interesting format. Yeah, I think that this is something that a lot of quantitative researchers, people that do a lot of hard data work, they're often told, objectivity is so important, but in spending a whole term actually thinking about this topic and interviewing a lot of different activist scholars about this, I think there's two things I want to mention. First is that there's no such thing as an objective science, like there's no value-free science, and there's a debate in academia about this, and you can kind of spend the time reading it, both sides like I did, or you can kind of take the gist from this and saying that even the tools that we choose to use to measure things and, the decisions we make about the questions we're going to ask, you might think that they're objective, but they're all coming from somewhere. And when we don't acknowledge that they're coming from somewhere, we're just kind of pretending like they're objective, but they're actually not. You might read something and you might experience something in life, you might notice something, and that might put you on a path to ask certain types of questions. And something that qualitative researchers often do is we just acknowledge that. And oftentimes, in academia, it's been seen as a weakness to be informed by personal experiences, or you have to maintain a sense of like a false sense of objectivity and professionalism. But some of the most impactful work comes when it's addressing community identified needs. So I think the funny paradox is that people want our work to have people want research to have such high impact, but they don't actually spend time talking to community because there's some perceived conflict of interest or there's some perceived ethical dilemma. But I think in acknowledging and working transparently through that, you're going to hit all the targets. And I mean, we have an ethics research board. We have peers who are helping hold us accountable. We have so many different tools as researchers to maintain a sense of positionality and a sense of objectivity, but not doing so in a way that's just misguided and for who? Like a performance of academia, So I think that being a community engaged researcher means sitting with the duality, and of course there's lines and there's boundaries, but I think that there's been such a historic and ongoing culture that people need to have a division between the two. And I remember actually a conversation with somebody, Dr. David Boyd. He's a pretty well-known human rights special rapporteur, and he's actually in my department. And I remember a year after I got in, I think I had a meeting with him, and he said, one of the reasons I was accepted into the program at University of British Columbia's Institute for Resources, Environment, Sustainability is because of my community engaged experience, because he says, you're going to be able to do work that people just can't do because they're going to spend so much time trying to build connections and networks with communities, and you already have those networks and communities and obviously can continue to grow them, but coming at this research thing with the experience of both being a community member and then having built over 15 years deep connections to grassroots movements, it makes it so much easier to ensure that the work I'm doing has direct impact, and it's moving a lot faster than trying to approach it from just the academic perspective and so forth. So there's always challenges. Sorry for the long answer, but it's definitely something I think a lot about, and I'm always navigating the ethics of it, but I don't think it's not worth it. I think it's actually going to make you a stronger researcher and make sure that your work has really good impact because it's really informed by the communities that you're hoping to help.
Thanks, Mavi. And, long answers to complicated questions, I think that's totally fair. And I wanted to follow up on that. I think it was highlighted nicely by Jonathan that a lot of people in this room and all of the speakers pretty much are wearing a lot of hats in their life and balancing a lot of positions and a lot of jobs depending on where you run into them. So I just wanted to invite if anybody has any other reflections on, is there any other conflict that you also see in wearing your different hats as a researcher and anything else that you do, and how do you mitigate that conflict?
I can jump in. It's Laura again. I did some thinking about this, doing research as a blind person in blind community, but thinking more generally about doing quote unquote insider research or insider work. So you belong to the community, and yet you also occupy a position of power in that you are associated with the university and you're doing this work and it benefits you in a particular way if you're a PhD student or a researcher. And so I think we don't always think about the ethics, like very complex ethics in that, and also the ethics in terms of care for the researchers. So if you're doing research with members of your own community, there are certain ways that that impacts you as a researcher, and I think it's really important to be mindful of that and to be asking yourself questions around that. So it's not just the community partners or participants who you need to care for, but you also need to really care for yourself when you're wearing those two hats.
Thank you, Laura. Anybody else any remarks?
It just reminds me of back in the day, nothing for us without us. That was the mantra of the HIV movement in the early 80s. And so I think sometimes all I have to do is remind myself that I have a right to be here, and I have the passion to be here, and I made the choice to be here. And my sisters and brothers that walked before me that weren't as lucky to have lived to the third cohort with the best drugs. So they weren't dying because I'm not going to die because of the drugs. I'm going to live a life that I would argue is long and healthy, but full of side effects, there's other considerations as a woman living with HIV. I appreciate what you said though about that. But yeah, I think that wearing the hat of lived experience comes with responsibility. And with that responsibility comes with acknowledging that not all women have the voice and so, to be at these tables, to participate. And so I'm very mindful of that privilege that I possess as a woman living with HIV.
Thank you, Shirley, for saying this. And this is, yes, Jonathan?
No, go ahead.
No? Okay. This is just something that I just, reflecting as a person in academic space, I think health equity is about having all the stakeholders at the table. Event like this is quite unique that way, and we are talking about health, we have lived experiences, we have researchers, and we have clinicians as well, and I think it's the way to go. My next question, which is top voted question now, and I'm really glad to see that people are expressing their opinions about what they want to discuss, is to our clinician on the panel, to Mei Ling. And it is about what can clinicians do within an extremely rigid health system to advance health equity, in your opinion and from your experience?
Oh, such a good question. Because it's like the question every clinician is asking themselves constantly, and it's hard. And so I think what helps is to really see the connection between the structural determinants of health and the individual actions that you take on a day-to-day basis, and to connect those throughout the work that you do, to find those opportunities to just take time within that system, to resist the structures in the system, even in the amount of time that you take with your people that are in front of you who are in your care, to take the time to just fully appreciate and treasure the humanity and dignity of the person in front of you, and just never waver in that belief. And so when you do that, the structures fall away a little bit, and you have the opportunity to be a little bit creative. So when someone's in front of you, you can take a moment to make sure they're comfortable, that they feel they have space and time to speak, that they are supported to speak in the way that they need to be supported. In my context, that's often we worked with cross-cultural health brokers who provide some language and cultural interpretation. Other people might use other forms of interpretation. Other people may require other types of communication devices. Whatever someone's needs are to be able to make themselves heard, you can attend to that. Even within the rigid structures of our healthcare system, which are constantly pressured by time and scarcity and all the things, I just try to remind myself that every time I make that space, it's a way of resisting and pushing back against those structures. And when I see the person in front of me as fully human with all their dignity, and then I act accordingly, it actually becomes fairly straightforward. If someone is struggling to find food, we find them food. Sometimes we'll give them food, and sometimes what we do as a collateral action is look at ways to bring them extra income, recognizing that, in fact, the reason that they don't have food is because they don't have enough money, and the structures that we live in don't allow them to have enough money. So is there any way that we can find an extra way to get them extra income so that they might have a little bit more opportunity to have the food and diet that they need? We take that time. And every time we do something like that, we think of it as this is a way to push back against those structures and make those connections on an individual basis. So it's not easy, but if you think about it that way, it feels better. It doesn't feel as morally compromised as it would if you were just kind of ignoring those pieces and just kind of giving in to the rigid structures. I don't know if that makes sense.
It does. Thank you.
Awesome.
To all these questions, there are really no easy answers. So yeah. And I mean, after this perspective about what clinicians can do, I think it nicely links with Jonathan's presentation about what people are doing every day already to man the gap that they can see in the healthcare. So question to you, Jonathan, 3-part. It's a little complex, but I'm merging a couple questions in one. So there's this very awakening paradigm shift, right, where patients are educating their care providers. So part 1 is could you tell us more about how they practically share this information with the care providers? How does it work? How is it perceived? And number 2, do you think, what does it mean about the medical education and training that there is a need for that? And is it responsible to shift this responsibility onto patients to educate their care provider? This is very, yeah.
Those are good questions. I think thinking about the second question first, there's a lot of dialogue about medical training, and it seems as someone who has not gone through medical training myself or health professions training, my observation is that more and more is added every year. There's constantly more research, more input, more things to know and absorb as a trainee. And so it's an interesting question, asking okay, can we justify adding more awareness and more knowledge? And that's kind of why I chose to approach my study from the aspect of equipping patients with knowledge to be able to inform their physicians or their care providers. But I think more can be done in the space of during training to open trainees and future healthcare providers' minds to thinking about patients in a different way, being able to conceive that a patient could have valid and important knowledge that you don't necessarily have. That might come from lived experience, that might come from community involvement. Those are both things that are relevant in my realm, but they come from other places too. And that kind of bridges to the first question, I guess, because one question that I get a lot is, how is this valid knowledge? Yes, there is a lot of research and a lot of data that shows that PrEP, in my case, is a safe and effective tool. But we've all been through COVID. We remember, all the crazy things people were trying to get. Yeah, I'm sure you remember all of them.
We're all over the place. Although you never know, sometimes things work. So
it's true,
yeah.
But it becomes a very interesting question. How do you have a conversation about listening to a patient and valuing what they have to say? Where does that knowledge that they're telling you come from? And that's something that I'm kind of grappling with in my research now. Is a lot of the tools that I'm encouraging people to use when they communicate with their providers often come down to this knowledge is actually validated by your colleagues, which is not a very satisfying or community uplifting sort of message to deliver, but it's often more effective, for better or worse. So those are kind of my thoughts around that. I don't know if that's really long-winded, but.
Yes, thank you. Yeah, I mean, Mei-Ling, I'm just curious, you would be on the receiving end of like this communication. Do you have any like cases when patients were communicating something to you, and like how did you feel about that?
Every day. I really enjoy my work, and I learn from people all the time. I think the answer is really to, rather than have medical training be about every single thing you could possibly know, because it can't be and it evolves all the time, is to really just have an orientation of humility that goes into everything that you do. Recognizing, again, the just firm belief in the dignity and humanity of the person in front of you, understanding their worth, their knowledge, where they come from, and what you have to learn, and knowing like you could never possibly know all the things. So I just might not know about that thing, and if someone brings something to me, approaching it with curiosity. You know, if somebody were to bring something new to me, I think my general reaction, which does happen a lot, is just, that's interesting. Like, let me find out more about that. You know, I might have some questions. I might need to do a little bit of research on my own, but I'm really interested to hear, and I want to know about why this is important to you and what it might bring to you, and if you need it right now, let's figure that out. You know, I think is just having that orientation is really helpful, because I think somebody did a study that was really dear to my heart, which I think about all the time, which is that if every, primary care provider were to follow every recommended guideline for just screening, it would take them 11 hours a day just for the screening, not even the other issues that people come in with. And I think that's something important for researchers to understand, is that anytime you're trying to develop something that you want clinicians to do and you're like, let's make a guideline, just remember that I am literally drowning in a sea of guidelines and I might not see it. So I think just thinking about how can we orient other sources of knowledge to come in, and then make sure that our medical trainees and other clinician trainees have an orientation towards humility, kind of brings those things together.
Thank you. That was a good answer, right? Something that I think about often, and I'm biased because I'm in HIV research space, but I feel like HIV community faces so much stigma and discrimination. They always do things first, and then like a lot of other fields follow. So hopefully that's going to be the case with a lot of good things as well. I would like to follow up with, so we only have time to 3 more questions. If you're reading the questions and you're like, this is great, I wish you could ask that question. I think the same thoughts, but I have to make some executive decisions here, so I apologize. But the next question I'm going to ask is going to be to Shelley, highly voted question. Could you please expand more on the training for community research associates? For example, what did the training entail? What was the time commitment? How were participants, or I think the person's referring to, like, how did you become community research associate and things like that?
Okay, so we came together I think I remember hearing that I got the job in February of 2020. So we literally went into the pandemic doing our training. And so there was no in-person, we were all on Zoom. There was 4 community research associates hired, and we had never met we hadn't met each other, we hadn't met the PIs, we hadn't really connected at all as a team. So all of that happened on Zoom, and including probably cat videos and stuff, dogs, babies. There was other videos that came in around that time when everyone was trying to figure out how to Zoom. So that was one thing, that was one piece. And we went through training, I think I would estimate 20 hours a week, 15 to 20 hours a week for the first 4 months. And so we covered everything. We did TPS, I'm gonna say this wrong, Tri-Council, that's that one. We did that one. And then we started off doing cultural safety in clinic. We did bullying and harassment policies. We did gender Later on, we did gender education, but we learned how to, well, at the same time, while we were being trained, we were also being instrumental in formulating the questions for the study. So there was two parts to the study: the clinical visit, which also involves a survey and collects the biospecimens, and then the second part was the community survey, which the community research associates administered, and/or a coordinator if one of us wasn't available, which wasn't very often. So the training, I would say we kept going on to the point that I believe we soft launched in July of 2020, I want to say, maybe even later, September. Helene, help me here. December, was it? Okay, thank you, Tanya. So, all of that time we were in training. It was extensive. It was not like, here's a couple of things you got to follow online. This was weekly Zoom meetings. This was homework. This was making sure that we knew what we were talking about and that we could feel confident talking amongst our peers who were research associates, PhD candidates, doctors, sometimes our own doctors, that we had to actually navigate that. I personally fired my doctor because I wanted to work with her. So I didn't fire her, she fired me, but you know how that goes. It all worked out. But it was extensive and it was ongoing and it continued and it continues to this week. Like we get training sessions, we have monthly meetings as a team, and then we have bi-weekly team meetings. We are right now doing some work with McMaster University, learning the engaged modules in terms of survey evaluations. We did stuff like go to the lab, we get opportunities to contribute to abstract writing. We are now in the process of possibly writing our first abstract to CAR next year. We'll see, fingers crossed. But yeah, it's been, when I say the highest standards in Canada today, I'm pretty confident I'm right. I'm pretty confident. So I'll just leave it at that. Thank you for the question.
Appreciate the short answer, Shelley. There's so much to say about it, but I think Shelley nicely highlighted also how technology was a lifesaver during the training period. So I would like to wrap us up with a question about technology, and that's a question to Andrea. So what challenges do you see in using technology to meet the needs of diverse populations in your work, and how do you think they can be addressed?
That's also a pretty big question. Yeah, so I've highlighted a few things that I've found in the literature, of course, the time to develop relationships and language, the mapping of resources within communities. So it's technology, the intention. So what I'm finding with when I'm working with this group of public health nurses is that there's definitely a hesitation around talking about, I'm interested in looking at the technology that you use and how you use it, because there's this idea that it could be this or nothing. So you either get technology or you don't get anything, and so we can pull resources because we've got this technology that says we'll connect. And so it's about changing the conversation to be about the hybrid model. How do you implement this in addition to the preferences that your clients and the individuals have, their situation, their language situation, and how do you make it best meet their needs? And I've been grappling with how to approach the conversation, because we've definitely demonized the idea of technology. And when I hear the panels talking about we're assuming from a point of in-person, and now with chatbot and AI, how do we do this stuff alongside technology that's advancing at a rapid race? So my answer to the question is really Not seeing it as necessarily used or not used, or have not, but how do we build this within a hybrid model so that we can, address the needs as they come and be able to meet the families where they're at.
Thank you. And yeah, I agree. Just like that, we are out of time. So I would like to invite everybody who has more questions, I hope you do, to continue the discussion at the networking space outside. There's going to be dialogue rooms if you signed up for them. But to close us off, I would like every speaker, starting with Laura and just going that way, in 1 to 2 sentences, answer the question, what gives you hope for health equity? So that we leave this room hopeful.
Oh, these people give me hope for health equity.
These people give me hope for health equity.
I guess I'd say the stories we have yet to write give me hope for health equity, that we can still change the conversation with both the scholarship and the creativity in the room. I think we can do things better.
Oh gosh, all the good answers have been taken. I think conversations like this give me hope, having them with lots of people. And I also really wanted to take an opportunity to say thank you to Brenda, who was instrumental in bringing us all onto this panel and wrangled all of us. And I'm sure it was torturous, but thank you.
I think women in research, and seeing this lovely woman sitting beside me and all of the women in the room. The ceiling has been broken, so let's just keep pushing it further and further. And I think it gives me hope to see women in research, and it gives me hope to see women living with HIV, having tools to advocate for better clinical care.
I think, as much as I love research, I think just going out and doing stuff gives me hope. So I think just like community engaged action, like as much as you can kind of see from the presentation I gave today, like I spent 75 to 80% of it just talking about like stuff that I care about. And I feel like that kind of reflects like where my hope lies a little bit. So get out there and do stuff.
I think my hope comes from the fact that we're starting to value some of these other forms of knowledge when we're trying to make decisions and advance health equity. So patients and research give me hope for the future as well.
Similar to what's been said, also echoing all the good answers. I think I learned this from also another sort of activist scholar, Marian Kaba, who says, hope is a discipline. It's really about what you go out and do every day. And so I think I would concur, is what gives me hope is actually the doing of hope. Going out, doing something every day that struggles alongside everybody else to make a difference.
Thank you, everybody. Let's go out and do some stuff then, to quote Manvi, okay?